Welcome to PALS. It's Professor Anyanwu's Anatomy Lecture Series. In this place, our goal is to make anatomy simple. If you're just joining us or you have not subscribed, we'd like you to subscribe now and be part of this amazing anatomy family where we make anatomy simple.
Hello, good day. My name is Anyanwu Emeka. I'm going to give 7 minutes lecture on the clinical anatomy of the knee joint.
This will serve as my outline. The knee joint is a synovial joint of modified hinge variety. This joint has the following articular surfaces: medial and lateral condyles of femur, trochlear surface of the femur, articular surface of the patella, and medial and lateral condyles of tibia. The joint is surrounded by a number of ligaments. The major ligaments are the capsular ligament, ligamentum patella, tibial and fibular collateral ligaments, anterior and posterior cruciate ligaments, medial and lateral menisci. We will consider some of the ligaments. The capsular ligament wraps around the articular margins of the joint, but is deficient anteriorly, where it is replaced by the patella, quadriceps femoris, medial and lateral patella retinacula, and ligamentum patella. Ligamentum patella is the tendon of insertion of quadriceps femoris, which extends from the apex of the patella. At its point of attachment at the tibial tuberosity, it can be inflamed, and when this happens, it leads to Osgood-Schlatter's disease. The tibial collateral ligament has two parts, the superficial and the deep part. The deep part is short and blends with 1. The fibrous capsule at this point, and 2. with the peripheral margin of the medial meniscus, as you can also note in our two illustrations. This is the fibular collateral ligament. Unlike the medial collateral ligament, it is not attached to the fibrous capsule, but separated from the capsule and lateral meniscus by the tendon of popliteus muscle, as you can also see in both illustrations. We have two cruciate ligaments, the anterior and the posterior. They basically maintain anteroposterior stability of the knee joint. They are named according to their site of attachment to the tibia. For the intracapsular discs, we have two, the medial and lateral menisci. The medial meniscus is more fixed to the capsule and is less mobile than the lateral meniscus. Hence, it is more at risk of injury. These menisci deepen the articular surfaces of the condyle of tibia and partially divide the joint cavity into the upper meniscofemoral and lower meniscotibial compartments. Flexion and extension of the knee take place in the upper compartment, whereas rotation of the knee occurs in the lower compartment. There are 12 bursae around the knee. We will consider the anterior group and one of the bursae in the medial group. Here is the subcutaneous prepatellar bursa. Its inflammation leads to a condition known as housemaid knee. Here also is subcutaneous infrapatellar bursa. Its inflammation leads to the clergyman's bursitis or clergyman's knee. And that's the deep infrapatellar bursa, and here is the suprapatellar bursa. The suprapatellar bursa communicates with the joint cavity. Medially, we see the anserine bursa, which is the bursa that separates the tendons of sartorius, gracilis, and semitendinosus from each other and from the tibial collateral ligament. Its inflammation leads to pes anserine tendinopathy. Structurally, the knee is a weak joint because of the incongruence of its articular surfaces, but is strengthened by the surrounding muscles and ligaments. Flexion and extension are the principal movements in this joint, with a passive simultaneous medial and lateral rotation. Because the knee joint is involved in weight bearing, and to reduce the amount of muscle energy required to keep the joint extended when standing, it has an efficient locking mechanism done through medial rotation of femur on the tibia during the terminal phase of extension of the knee. This is known as screw-home mechanism. To initiate locomotion and flexion, it also runs through an unlocking mechanism done through lateral rotation of the femur on the tibia during initial phase of deflection by the popliteus muscle. The menisci can get torn during forceful rotation or twisting of the knee. There are various patterns of meniscal tearing depending on the cleavage plane, such as vertical tears, horizontal tears, bucket handle tears, etc. Injury to fibular collateral ligament occurs when excessive outward force, called varus force, is applied to the medial side of the knee. This injury is less common compared to the tibial collateral ligament. Injury to tibial collateral ligament occurs when excessive force, called valgus force this time, is applied inwards to the lateral side of the joint. Injuries to tibial collateral ligament can be part of a condition called unhappy triad. In this condition, there is an injury to the tibial collateral ligament, tear of the medial meniscus, and anterior cruciate ligament. We use TAM. Genu-valgum or knock knee is a condition where the angle between long axis of thigh and leg is reduced laterally, while genu-varus is a condition where the angle between the long axis of thigh and leg is increased laterally. Osteoarthritis is a degenerative joint disease, which also occurs in knee joint. Total knee replacement or knee joint arthroplasty can be done in severe destructive arthritis of the knee joint. The iliotibial tract can be irritated as a result of its close relation with the lateral condyle of tibia, and this can elicit sharp pains on the lateral part of the knee when patient is squatting or is flexing at the angle of 45 degrees. Fracture of patella is a frequent problem and does not heal as it is a sesamoid bone. In acute traumatic synovitis, joint cavity is distended with fluid and swelling is seen above and on the sides of the patella. Thank you.